Good evening, everybody, and welcome to this evening's Facebook Live. My name's Alec, and I'm joined this evening by the wonderful Sarah Gardner. Sarah, are you there?
I am. I'm here. Thank you.
Excellent. Thank you very much. And tonight's session is leg ulcer assessment, getting it right first time. And we have this event this evening sponsored by the Ergo Foundation, which is a fantastic organization which works with healthcare professionals and patients alike to support scientific research and innovation and development within the wound care sector. And they award grants and prizes to healthcare professionals. So do check them out. We'll be putting some links on the screen later in the presentation. As always, certificates will be available at the end. So please do keep an eye out for those links. And you'll see that we're both in our houses, as we have been for the last 2 years for obvious reasons. So if we do have any technical issues, please do bear with us. Sarah, that's it for me. There's not really anything more for me to say. So I'm going to keep it short because I know you are itching to start this presentation. So Sarah, have a fantastic time with the presentation. I'll be back for the live Q&A once you're done. So just one final thing just to say to everybody, thank you very much for joining us, obviously. Please do ask as many questions as you can, because once the presentation is over, myself and Sarah will come back and we'll be answering as many of those questions as we can. So I'll catch up with you very shortly, Sarah.
Thanks very much, Alec. Thanks for the introduction, and thanks to wound care people and for Ergo for inviting me to speak tonight. Tonight, I will be focusing purely on leg ulcer assessment, not management. At this stage, you know, this stage assessment is really essential, and you need to be confident about undertaking this particular part of leg ulcer management. Assessment is really key to this process to make sure that you can establish a cause of ulceration or why maybe it's not healing properly. Hopefully you'll go away tonight with either new knowledge that will improve your practice or reassurance that you are currently doing everything correctly. Just post some questions as you go along, and then I'll take some questions and hopefully be able to answer them at the end of the session. So why are we still talking about leg ulcer assessment? Some of you might think, oh, blimey, why are we still talking about it? There is a plethora of evidence out there, isn't there, that tells us that assessment is important. If you think about data from studies such as Julian Guest's work in 2012, 2013, and again in 17 and 18, it confirms that assessment is still not consistently being carried out. If you think about lower limb, up to 30% of patients don't have a definitive diagnosis. So the likelihood is that they haven't been assessed properly. I'm not sure about yourselves, but if you've been involved in any local audit, the chances are that that audit provides evidence that still assessment isn't being undertaken. And patients are talking to us about their experiences. You know, we're hearing stories that maybe are very uncomfortable to us. You know, they're uncomfortable to listen to about the pain and the suffering that people are experiencing with leg ulceration. And you just really need to ask the question, why are their wounds still open? Why haven't they healed? So why haven't we got to the bottom of that? And sometimes it's because of the lack of assessment that we haven't established that reason, really. We have the National Wound Care Strategy Programme, amazing programme that's been commissioned by NHS England, and hopefully, or if you haven't done so, I'd urge you to read their lower limb recommendations, and assessment features massively in that. So they're telling us that we should be undertaking that as part of our leg ulcer care. And campaigns such as Legs Matter, I'm privileged to be chair for this amazing campaign now. You know, we can be quite hard hitting with what we're trying to do, because we're trying to get people to really think about the delivery of leg ulcer care and the role that assessment has in that. So why isn't assessment happening? Well, we know there is a high turnover of staff. Most of the care is delivered in the community, and we know that there is a turnover of staff. So it's difficult maybe to get people to that level of competency and to sustain that We know that is difficult, but there needs to be a strategy for managing that somehow. Time is an issue, isn't it? People say they haven't got enough time to assess properly. Unfortunately, this flipping COVID-19 pandemic hasn't helped either. And unfortunately, some services were stepped down in terms of wound care or leg ulcer care. There was a big push for self-care, but not always those decisions were the right decisions to make. And access to training during this period has been really tricky, with either no training or all being virtual, which sometimes, hasn't been able to get people to develop real practical skills. A lot of the delivery out there is by nurses who have a very generic role. So there's a lot of skills to learn. We get that, you're juggling a lot of balls, and the leadership that supports you maybe doesn't put leg ulcers as a priority. But the brilliant thing is that you're here today, and hopefully you will take home something, or you're in home already, but you'll take away something that you will be new learning for, that you can do differently. So why is leg ulcer assessment so important? It's a bit of a cliche, really. We're always saying it is, but it's absolutely true, isn't it? When you're talking about leg ulcer assessment, we should be providing a holistic approach to this, to look at the condition. That old expression that we say, look at the whole person and not the hole on the leg, or hole in the leg. I know it's, again, a cliche, but it's absolutely true. Because assessment will provide you with really important information that will establish an etiology or diagnosis for the patient's leg ulcer, and also help you identify risks for healing. Because even though you might get an etiology, by assessing properly, you can then start to identify what will make this ulcer tricky to heal. Because it's not just about sort of the, I suppose, the systemic issues that go on. There's an awful lot about the patient and their environment that would make that healing tricky. Assessment provides you with a platform from which a treatment plan can be formed. Because if you haven't got that assessment and therefore haven't got a diagnosis, how do you know which treatment plan to go down? You could go down the wrong treatment plan, which then would compromise patient safety. But also, and what is really, really rewarding, is that assessment will provide a baseline from which you can measure the outcomes. So when you've put a treatment plan in place, base that on your baseline. So 4 weeks down the line, how much improved is that leg ulcer? And that's really motivating for you as a clinician, but also for your patient as well. So how should a leg ulcer assessment be carried out? Well, as I've said, it should be holistic and patient-centered. And it's really important that you prepare your patient for it. People talk about the amount of time that's required, but you don't necessarily have to do it in one hit. You can chunk it up a little bit. But honestly, the time invested in doing this properly will save you time longer term. So you need to have that conversation right at the beginning with your patient about what you want to undertake and why you're doing it, because otherwise they might be quite confused about the interrogation that you're undertaking. And also they can prepare, if they know that you'll be asking certain questions. Now, you might have a leg ulcer assessment form that you used in your local areas. So do use that. You need to be following your local sort of policies and guidelines for doing this. And that sometimes will help that process to be quite systematic, and therefore things shouldn't be missed. But also it does help with the flow of assessment as well. But saying that, don't let it be too rigid. You're dealing with a human being here, and therefore, you should allow the patient to sort of take you where that assessment is going. What I'm really passionate about is that assessment should trigger curiosity. It's like reflection on action. So it's about, ooh, that's interesting. Right, yeah, I get that. I wonder why that is that particular colour, or why is the patient presenting with that symptom, or what is that? What's that significant of? So all the time in your brain, it should be triggering the, You know, what does that mean? Is that important? Is it relevant? That sort of curiosity. And I want you to use all your senses. It's not just about what you're seeing, it's about what you're feeling, what you're hearing from your patient, and what you're smelling as well, because part of your assessment will include that. Assessment should trigger that light bulb moment. So those of you that have already got some knowledge and skills, it would be, haha, I know why that is the way it is. That's why, you know, it looks that way. It's because of this. It's those light bulb moments. You know, it's quite exciting. It's also a bit like being a detective. You know, you're putting, you know, little pieces together. But what I don't want you to do is to be tempted about the what now. I don't know what about yourselves, but sometimes when we're assessing, we've got this little voice in our head which is distracting us, because it's going on to the next question or it's going on to a plan. So when you get a little bit of information, your little voice might be saying, what I need to do is, you know, refer, or I need to be doing this, or I need to be thinking of that. Try and stop that little voice, because what you need to be focusing on at this stage is the assessment. So it's the interpretation, the curiosity that you know, why is that happening, rather than this is what I need to do. That little voice does get in the way a little bit. And then document everything as you go along, but don't allow it to become a tick box exercise. As I said, you're dealing with a human being here. You need to document, because if you're anything like me, I can't retain everything in my brain, but don't allow it just to be a tick box. So if you think about the National Wound Care Strategy recommendations, this patient that's in front of you now, it could be that they have come to see you because 2 weeks ago they bashed their leg on a car door, or it was a gardening injury or whatever, and that wound isn't getting any better, or it could be getting worse. Now, you might not have known what that patient was presenting with necessarily today. So what the wound care strategy is asking you to do is that you need to be considering that immediate and necessary care. So what does that mean? Now, you don't need to today undertake that big holistic assessment. All you're doing today is doing a bit of a check, putting in immediate and necessary care, and then you're referring on, okay? So what you need to be doing at this stage is to assess your patient against 5 red flags, because that will help you detect any problems that are presenting today, and then you'll be able to then refer or get the necessary intervention to avoid any future harm or suffering for your patient, okay? But also today, that if you eliminate those red flags, the National Wound Care Strategy is saying that you are fine to put on reduced compression today without a Doppler. But if you identify today that that patient's wound is problematic because it's not healing within 2 weeks, you would refer that patient to a healthcare professional with additional skills in leg ulcer assessment, and they should be seen within 14 days of you referring from today. So those red flags, what are they? So they should be pretty obvious to you. Acute infection, so, you know, a deteriorating wound with the presence of cellulitis and pain, for example. But also you need to be, you know, are there systemic changes to your patients? Are they feeling a bit unwell? Have they got a tachycardia or a pyrexia? And it's really important to eliminate sepsis. So using a tool such as NEWS, the sepsis assessment tool, to see whether there is deterioration in your patient. You're also ruling out acute or chronic limb ischemia. Pretty obvious to see. Is there pale limb, painful limb, mottling of the foot, for example, or signs of necrosis or gangrene? Is there a suspected deep vein thrombosis, hot, swollen, painful cough, for example? Or is the lesion on the leg looking a bit unusual, raised, bleeding, has been there for a while without any improvement? So these are the red flags that you're assessing against, and if any of them are present, you would refer immediately to get some advice. Okay, so you've ruled all those out. You've referred your patient to a clinician with advanced assessment skills in leg ulcer. Hasn't got to be a tissue viability nurse. It could be either yourself, because you've undertaken a course, for example, in leg ulcer assessment, or it could be a colleague, for example. So that patient presents today then in front of that clinician, and a holistic leg ulcer assessment should include 3 main components. So patient assessment, which would be looking at intrinsic or internal factors that maybe would help with diagnosis or healing risk, and extrinsic or external to the patient. You would then undertake a lower limb and vascular assessment, and then finally a wound assessment. And as I said, this should be completed within 14 days of the immediate and necessary care intervention. Okay, so patient assessment intrinsic, what does that mean? So much of this information can be gathered before you even see the patient. People talk about the lack of time. If you go on to System 1 or EMIS or whatever, wherever the patient's information is collected, you can pick a lot of this up from that system. And then you can maybe just clarify or expand on that when you're in front of the patient. How is the patient today in terms of their physical and mental health? You know, are they able to sort of, you know, be a partnership, a part of this assessment process? Have they got the mental capacity to be able to be giving informed decisions, for example? Think about underlying medical conditions. There are certain conditions which would impact on ulceration but would be problematic for healing. So, for example, if patients have diabetes, or they have peripheral arterial disease, already that sort of interpretation, that sort of curiosity would be thinking, well, you know, the chances are that this might be associated with an arterial element. What other information do I need? And there are certain conditions such as rheumatoid, so those autoimmune disorders, which will make healing complicated. What's their blood pathology? Are they anemic? What's their renal function? What's their platelet function? Again, you know, if they haven't had bloods taken for a while, get yourself a set of bloods taken. Past history of surgery and trauma is important, because if they have had that to the lower limb, that could have damaged the venous system, and therefore already you're thinking, have they got problems with the veins? The valves in the veins have been damaged because of trauma or surgery, and this might be more likely to be with a venous problem, as would be a deep vein thrombosis as well. Have they seen a vascular surgeon in the past, or a podiatrist, or a tissue viability nurse? How did that consultation go? Was there a diagnosis made at that point? How about medication? Again, there's some medication that could cause some complications for healing. You know, steroids, for example, or chemotherapy-based medication are all problematic. Are they allergic to anything? And what I want you to also think about is their mobility and gait. Is there a disability, for example, that impacts on their ability to mobilize properly, and their gait that would maybe compromise that sort of calf pump action, which is so essential for venous return? And then you're considering things like their extrinsic sort of factors. So what is the environment the patient is living within? Is that risky for yourself as a clinician? Or how about that environment in terms of the patient and their ability to sort of take on board a really therapeutic plan with you? Have they got a support network of family and friends when maybe you might want to consider supported self-care? Are they a carer? There's been numerous times that I've looked after people with terrible leg ulcers who are caring for other people, and therefore, you know, they're constantly on their feet. They never go to bed, so their legs are never elevated. Don't forget that people with leg ulceration aren't necessarily elderly and have retired. There are people who are trying to hold a job down, you know, reliant upon that job for income. How will this impact this problem that they've got on that? And their lifestyle in terms of smoking, drugs, alcohol, diet and exercise is really important when you're embarking upon a treatment plan. How about sleep, which goes often with leg elevation? How many times have you had a patient say, yes, nurse, I definitely go to bed? And you know they don't. Sometimes we have a little sneaky look, don't we? And we can tell the bed hasn't been slept in. You know, they're in a chair, they say that they elevate their legs, but clearly they don't. And what is their experience of the, you know, the health service? Sometimes people have had a really rotten experience where maybe there's been a lack of compassion, a lack of care, there's been pain associated with that, and that tarnishes maybe the relationship that you hope to have. So do think about that, and also people's cultural factors and beliefs as well. So then we move to lower limb and vascular assessment. And within this assessment, you would be considering skin changes, shape, swelling, veins, and arterial status. And what I'll do is I'll just quickly go through all of those for you. So when you are assessing the skin, I want you to think about what the skin feels like. Take your gloves off. You can then wash your hands again and put your gel on, but you actually need to have gloveless hands to really feel the skin. What does it feel like? Does it feel hydrated, or is it dry or flaky? Does the patient complain of itch? Are there any patches that are weeping? When you're feeling the skin, is it painful for the patient? And ask them, what does that feel like? It might not be pain, it could be a sensation. A lot of people have neuropathic type of pain, which actually is described as more of a sensation than pain. Have a feel of the temperature. I tend to start at the foot and work my way up. Are there any real dramatic changes in that? And where does that happen? Again, think about both. Well, I want you to try and look at both legs, regardless of where the ulceration is. It's good to compare, so you're feeling the temperature of both limbs rather than just one. Is the skin looking fragile or vulnerable? And are there any lesions or spots present? And do they look a bit unusual? Area of scarring, for example, where there might have been previous ulceration. Is there eczema? What's that associated with? Is it varicose eczema? And ask the patient what they use on their skin to try and improve the condition of it. What type of emollient, or is it a very perfumed moisturizer that they use, which, as you know, is not good for the skin. And then you're looking at skin discoloration. So you might see this staining, which could be browny, purpley, bluey sort of staining, which is called hemosiderin staining or hyperpigmentation. And that's a really common symptom of venous disease. And it's due to the seepage of red blood cells from the capillaries into the tissue when you've got sort of tissue flooding because of venous disease. And once it's out and stained the skin, you know, you can't reverse that. But as I said, it is a sign of venous disease. Or there could be sort of these purpuric marks, which can look like bruising. But you need to be sort of exploring that, because that can be associated with maybe vasculitis or infection, or maybe problems with people's platelets. So again, it goes back to making sure that maybe you've had a set of bloods taken so you can monitor platelets. But you can get like a mottled effect of the foot or the toes, which could be associated with arterial disease. So you need to understand, you know, what that looks like and what that might be. And then you're looking for something called Atrophy Blanche. Now, it can be mistaken for scarring. It's like a white marbling effect, commonly around the malleolus or the gaiter area. And that is a symptom of venous disease. If you look closely, you might see some little red specks within the white marbling effect. What's going on here is, one of the theories is that when you have tissue flooding because of the congestion of the veins, you get seepage of fibrin into the tissue, and that can wrap itself around the little capillaries, causing like a local ischemic reaction. So it's not like arterial blockage. These are the little capillaries that the blood flow is being stopped because of the fibrin, and that is a really clear indicator of venous disease, and often a pre-stage of ulceration. It can be really painful, so patients will be describing that to you. But you know, you need to try and differentiate between what might be scarring from old ulceration and what is atrophy blanche. You then might be finding you might be seeing skin plaques or hyperkeratosis. This is a nurse's joy, where, you know, you've got skin plaques that they do like to sort of peel off, and you can get varying levels of that, from sort of mild flaky dry skin to quite thick hard skin plaques. Hyperkeratosis, you know, is a body's reaction to irritation or inflammation, which is associated with venous disease. So you get this overproduction of keratin, so you get this thick layering, but unfortunately it's not good for the skin. It harbors bacteria and fungi underneath it. It can become malodorous, and therefore it does need to be removed. So what you're looking for is the extent of that, so when you're planning care, you know that that is something that you need to manage, because you can get cellulitis as well as a result of this. Then you're looking at limb shape, and again, look at those legs. You're comparing the two. Are they different? And if so, why? You know, is the deformity in the shape associated maybe with a childhood disease such as polio, for example, or is it a deformity due to trauma? And don't forget to check the foot mobility as well, because there could be a deformity there which will impact on gait and the calf pump action. It would be, if the patient is able to mobilize, get them to their feet and observe the patient walking to see what their gait is like and how maybe that limb shape impacts on their mobility, because that will need to be scheduled into your treatment plan. And then swelling. So, you know, look at where the swelling is. Is it in the foot? Is it in the lower leg below the knee? Or does it extend to above the knee? Is it soft? So when you press it, like this picture on the top right, leaves an indentation, or is it hard and fibrotic? This is usually associated with edema, chronic edema, and can be really painful. So again, have a little press and see what the patient, you know, whether that's painful for the patient. Have a look and see whether any areas are weeping or looks a bit boggy, and that's usually like the advanced end of venous disease, so that lymphedema stage that you will need to manage. Ask whether the edema resolves or goes down overnight. And also, you know, ask when it started. You might find that swelling started decades ago, maybe after a pregnancy, and hasn't been addressed or treated, which is, you know, not great, is it? Veins are something to look at, and, you know, we should be looking at where are they. You know, that they range in severity. Varicose veins, for example, you know, do they are they behind the knee in the popliteal space or at the side of the knee? Because what you should be thinking about is when you've got, you know, your treatment plan, that could compromise where the compression finishes. So if you have below knee compression, for example, varicose veins that go up the back of the knee or at the side of the knee, could be problematic because it could be painful. So look at where the varicosities are and the severity of those. But there's also something called ankle flare. So you get this fan-like, more superficial, a bit like spider veins that are often around the ankle or the side of the foot. And that again is a really significant sign of venous disease, where you have this congestion in the veins where the blood isn't returning back up the leg correctly. So look at veins, where they are, and document that. So I've talked a lot about things that you might be seeing that are associated with venous disease, but also there are signs that would be significant for arterial disease. We talked about the coolness of the limb, so that is a symptom of arterial disease. But I don't know about you, but my feet are always cold, and I know I haven't got arterial disease. So there's cold and there's cold. People with arterial disease can have quite, you know, a chilled type. You feel it, it's dramatically cooler than maybe another part of the limb. The skin could be pale, but as I said, there could be purple or blue mottled skin as well. And there could be evidence of gangrene on the toes or in the foot, or foot ulceration. Ask about pain when they put their legs up and they go to bed, or they elevate sort of on a stool. Do they get pain there? And again, that can be an indication of arterial disease. And what about pain on walking? We talk about shop window syndrome. So, you know, people who are walking down a high street who've got arterial disease, when the muscle in the calf is lacking oxygen because of the lack of blood getting to the lower limb, it causes that person to stop because the pain is so significant in their leg. Intermittent claudication, we call it. So they stop and they look in the shop window, allow the pain to ease off, and then they move on again. So we often talk about the distances that people can walk before they get pain. But also there's something called a Berger test, so where you can elevate the leg above the heart to see whether it pales on elevation. You hold it there for about 30 seconds, and then you bring the limb down right over the side of the bed or over the side of the couch. Does it fill with like a ruber, a very red look? And that is a positive Berger sign, and that is suggestive of arterial disease. The icing on the cake of your lower limb assessment is a Doppler. It's essential we should attempt this. Everyone should develop skills to do it. I know there will be times when you can't do it, whether the limb is too big, the limb is too painful, the patient is too anxious, but it's not having the skills all the time is not a reason why we shouldn't do it. We should always attempt it. Using a handheld device is what we normally, there are automated devices now as well that people are using. So listen to the sounds if you're using a handheld Doppler. It tells you a lot about the quality of the sound wave. And what you're doing when you're doing this test is you're getting an index comparing the brachial to the ankle pressure. And these are the results. So a normal range would be 1 to 1.3. 0.8 to 1 is there's some mild arterial disease present. 0.6 to 0.8 is there's moderate, and under 0.6 is significant arterial disease. A result over 1.3 may suggest calcification within the medial wall of the artery, and you would be seeking some advice from a specialist before you embark on a treatment plan for this. And then finally is the wound assessment. And I say finally because a leg ulcer is a wound, and a wound is a wound. And you would assess this wound as you would assess a pressure ulcer or a dehisced surgical wound. So you would be documenting where on the leg the wound is, firstly, and then you would take a measurement. And I know there's a range out there. A lot of people do longest length, widest width. There are some people that would work out a surface area, say in centimetres square. If you're very lucky, you might have one of those fancy cameras that also work out the surface area for you, but I'm afraid most of us haven't got those. A photograph is really important because that is a great baseline, and when you're moving ahead with your treatment plan, it's motivating both for yourself and for the patient when you can see that difference. But also photographs are fantastic if you have to refer and you can send an image. And what I would suggest is you do a photograph close up to the wound, but also step back and photograph the whole limb where that wound is. So you're also looking about, does the wound look raised, or is it bleeding or itchy? Because we know that there will be some lesions on the leg which aren't normal, they're atypical, and you would need to be seeking some advice for that. You can use something like the Times acronym to assess a wound, which is really helpful. So it's again following a systematic sort of approach for this. So this would be T for tissue. So you're looking at the wound. How much epithelial tissue is there? Hopefully there's a lot. Or granulation, that lovely red granular tissue which demonstrates that things are healing. Or is there sloughy tissue or necrosis there? Try and work out the percentages. And as I said, the photographs will capture this as a baseline. I is for infection or inflammation. Now, how can you tell whether a wound is infected? There are tools out there that you can use. The Tilly assessment tool, which Ergo have developed, which is absolutely fantastic. It's called Therapeutic Index for Local Infection. It just gives you a bit of a checklist as to what you're looking at, as to whether this is locally infected. You know, increased exudate, pain, odour, sloughy tissue, pus, dark tissue, bridging, bleeding. These are all signs of local infection. But of course, we also need to make sure that there is not anything going on systemically. So I would suggest that you also need, in line with this, to be using a sepsis assessment tool such as NEWS, which would pick up the deteriorating patient. There are patients, especially the elderly, people with diabetes, where infection can be masked and people can go from being absolutely fine to being really unwell very quickly. So I would suggest you do the two together to rule out anything sort of really nasty that's going on. M for moisture, exudate. How much is it? Is it normal for this stage of healing? The chances are that you're dealing with a lot of chronic wounds with leg ulceration, so it probably isn't normal. It is stuck in the inflammatory stage, and therefore that's why this level of exudate is high. The exudate will be really problematic here, full of elevated MMPs, which are destroying all that lovely new matrix that's being developed. And therefore, you know, you need to recognize that and do something about it. And exudate really does need to be managed. Otherwise you get delay in wound healing, and the peri-wound skin can be really compromised. So again, you know, measuring, looking at the colour, looking at the consistency, and whether there's odour there is really important part of your assessment. And then look at the edge. You know, edges tell us loads, gives us lots of information. If you look at these images here, you know, what we need to be looking at is, are the edges rolled? Sometimes rolled edges can be significant of a malignancy or a really ischemic static wound. You know, the epithelial cells won't be able to migrate with edges like that. Look at that image on the top right. You know, that is what we call a pyoderma gangrenosum. It's an ulcer that's associated with an autoimmune disorder. Can you see that dark purple edge? That is not normal. It is atypical. So please, if you ever see anything like that, you should be asking for help. What is that? I need some help with this. You can get very ischemic dark edges as well because of the lack of blood supply. So again, look at the edges. What is it telling you? And do seek advice if you're stuck on that. And then the surrounding skin. Don't forget that. If you think about the skin, it is an organ, the organ fails. So apart from the wound, what's the knock-on effect? Is there maceration or is there excoriation? So maceration often it will be associated with unmanaged exudate. You need to protect that skin, but that excoriation is due usually to those elevated MMPs that are in the exudate that are really burning the skin, and therefore you will need to, to put a plan in place to manage that. So what now? You've gathered all of that information. It's an incredible amount, isn't it? So what is that information telling you? Hopefully that information should provide you with an etiology, a diagnosis. Going back to the Doppler, I'm a great believer that even without that, if you've done your assessment properly, that Doppler, which is ruling out arterial disease, or it's telling you what status the arteries are in. It's not diagnosing the venous ulcer, it's telling you what the blood flow is like in the arteries. but that shouldn't give you any surprises, because this information that you've gathered should give you a clear indication of what is going on with that patient's limb. It shouldn't give you any surprises at all. And then you make your diagnosis, and then you would be, what are your next steps? So in summary, a robust holistic leg ulcer assessment is absolutely essential to aid correct diagnosis. You know, do allocate enough time. You can't do this in 5 or 10 minutes, even if you have to chunk it up over a number of days, but hope within a week or two. Don't delay it too much. But you know, you need to allocate enough time to the activity. Don't allow it to become a tick box exercise. I think, you know, just in terms of time, sometimes we do that, but it has to be, you know, a thorough exercise. Be curious about what you're seeing and ask if you're not sure. Document those observations and findings, and involve your patient actively in this process. It's their limb, isn't it? They should be an equal partner in this sort of assessment process and afterwards in their planning process. And really be confident. Most of you out there today will know all this. So please be confident in what you're doing, because you're all brilliant at what you're doing. Thank you so much for your attention, and I'll take questions now.
Thank you, Sarah. I've been watching on Facebook, as I often do, just to see what people are saying, and there's lots of lovely comments about the presentation itself. Lots of people saying lovely things about how interesting it is, and we've had loads of questions as always. So I'm just going to crack straight on with those, if that's right with you.
Yeah.
So the first one is from Nicola, and this is: how do we incorporate assessment for dark-skinned patients within the assessment tools that are available?
Okay, so with dark skin, there are some signs that might be more difficult. So if you take, say, hemosiderin staining, for example, it might not be so evident on people with dark skin. It's very similar to, you might have seen a new document that's come out about blanching and non-blanching erythema when you're checking for pressure damage. So these are quite problematic with dark skin. But again, you know, I talked about the senses, so feeling the skin can give you a lot of information. So it might be warmer. So if you've got, say, some underlying venous disease that's presenting as induration, we call it, so it's sort of quite fibrotic tissue, you're feeling that, or it might be hotter. You would still get those areas of Atrophy Blanche, which should present in a very similar way, but use feel more than maybe observation, because it might not be so apparent. But the main sort of observation would be that hemosiderin staining, which might not be so obvious in dark skin.
Okay, there's a few documents that have just come out recently that I've seen about the place on assessment for darker skinned patients. At the later on, well, tomorrow, I think the presentation will be available on our website, and I wonder whether we may be able to put some links up there for some of those documents. I'll need just to get my team just to have a look at them, but I've certainly seen them over the last couple of months because it's been an issue that people have been addressing. So I hope that answers your question, Nicola. The next one is from Christina. This says, I haven't come across the Legs Matter campaign in my trust. How can trusts bring it to ward level? And I was going to say, you must be living under a rock, because it's been everywhere at the moment, hasn't it, Sarah? So, but Sarah can absolutely help you with this, Christina. So what can they do?
Oh, absolutely. So yes, there are people, as you say, I don't know where they've been, but obviously, you know, that's absolutely fine. I'm delighted that, you know, you've raised the question. So Legs Matter is still, you know, it's out there, and our main platforms for communicating about the importance of raising awareness about lower limb and foot conditions is our amazing website. So I would advise you as a starting point to go onto the website, so legsmatter.org, and there you will find two main areas, one for healthcare professionals and one for patients, family, carers, friends. You can go into either, you don't have to register. And really at ward level, it's about, just signposting people to those sites and the resources that are within. But if you have patients that come onto your ward that you want to advise or educate or raise awareness, do signpost them to the website. I know not every patient will have access to an iPhone or an iPad or whatever, but often family members do. And there are downloadable resources. You can always print stuff out and give it to your patients. But you can get newsletters. There's loads of information and exciting things that we're doing, and also all the resources from the previous awareness weeks we have each year, patient stories, videos, interviews with specialists. It's all there. So go onto the website, have a look, and take what you need from that.
I'll just add to that as well, and that is if you use social media, if you use Twitter or Facebook in particular, follow Legs Matter, because every time that you do something new, whether it's campaigns, because there's a Legs Matter week each year, there are various different campaigns and things like that, and every time something new gets put onto the website, you're very good at actually putting that out on social media as well. So that's how I'm often looking at your website, but it's often I've seen it or I've seen a post.
You're right, Alec. Yeah, so our website is like our major, but yes, we have a massive social media following, and as you say, we're always recycling our resources. There's been a lot of activity this last week or two. So yes, if you are on Twitter or Facebook or Instagram, there's always stuff. So yes, if you follow us, you'll find out what we're doing, and you can, we're always posting stuff out there. So brilliant.
Brilliant. Next question is, this is an interesting one, especially over the last 2 years in COVID. And this is, should it just be qualified nurses that assess the patient? It doesn't say who this is from, so I'm not sure whether this is from a
so when you look at recommendations, whether that's been sort of from previous sort of leg ulcer guidelines like SIGN guidelines or RCN, and also if you look at the National Wound Care Strategy, they're saying that the patient should be assessed by a clinician with additional skills in leg ulcer care. Now, this is that they've undertaken additional training to be able to do that. Now, interestingly, from what I can gather with the National Wound Care Strategy, it doesn't say it has to be a registered clinician. However, other guidelines have stipulated that. And in fact, they've always said that patients should be they should have an assessment by a qualified registered clinician. I'm not saying nurse here, because as you know, leg ulcer care is not just about nursing, it's the wider remit of professionals these days. And we know that podiatry now are extending their role to do a leg assessment as well as foot in some areas. So it tends to be a registered clinician who should undertake that assessment. However, non-registered staff are massively involved now in the delivery of leg ulcer care. So they're developing skills in compression bandaging and Dopplering to be able to support the registered staff in delivering that care. It definitely has to be a collaboration and integration of services and different sort of roles rather than just sitting with nursing, definitely.
And I think the answer is slightly different. If the question was rather than should it be just qualified nurses that assess the patient from a wound care point of view, if it was just should it just be qualified nurses that treat the patient with wounds, that's a very different question.
I think Alex, the thing is that registered nurses will have undergone, within their 3-year training, they do all the detailed anatomy, physiology, all the systems, it's all connects, and they've got that sort of wider knowledge base to be able to really interpret. Because it's not just about the gathering of information, it's the interpretation of what you're seeing, or, you know, that understanding, that putting the jigsaw puzzle together. You know, this shouldn't be task orientated. It's more than that. So, you know, we know that non-registered staff are now undertaking additional training. We've got our assistant practitioners now, people are doing apprenticeships, etc. But assessment should at the moment be undertaken by a registered clinician, but the importance of having our wider team to support the delivery of care, definitely.
Okay, brilliant. The next one is, you should be able to answer this. I was just wondering whether this was more of a question for the device companies. But what's the difference between the probe sizes used to perform an ABPI, and why would you use them?
Okay, so the two main probes that we use for ABPI are a standard 8, so that is the one that we tend to use for standard size limbs, and then I would always say that you need a 5 probe in your toolkit as well, and that's because the 5 will penetrate deeper. So if you have somebody with a lot of oedema on board, the chances are that you'll pick up the pulse better. So an 8 is standard shaped size limb for an adult, and a 5 would be if you have someone who's maybe due to obesity or due to a lot of chronic edema in the leg, you would need the 5 to undertake ABPI. So the 2 are required.
You answered that much easier than I was expecting. I read that and I thought that's a tough question, but you were on it. Well done. So next question is from Kate. Who specifically would you refer to if any of the red flags are present?
So it depends on the red flag. So if the patient has got some acute infection, I would imagine it would be the GP. Even if they have sepsis, it would be the GP, but probably the patient then would be referred to the GP and would probably be admitted. Depends on the level of urgency. DVT, most of these referrals, if the patient's in the community, would go via the GP, because they are the gateway, aren't they, for referring on to whether it be vascular, whether it be acute medicine or whatever. So I think your first point of contact would be the GP, but obviously when you're there, and if there's anything like, you know, the patient is really unwell and is deteriorating in front of you, you would do a 999, I would imagine, and you'd get them in that way. So yes, but then depending on what the presenting red flag is, whether it be vascular or medicine or whatever.
Okay, fine, thank you. The next one is from Kate B. Which bloods would you suggest for a non-healing wound?
So I would always do just a first line set of bloods, which would be a full blood count, an ESR, a CRP, and U's and E's. If there's any sort of history of, depending on the presenting conditions, occasionally I would do a liver function test as well, but not routinely. So that would give you the basics. And from that, you might want to then discuss with the GP the presentation of the patient, maybe what's going on, and you might need to do other inflammatory markers. But all I would say to you is speak with the GPs, because sometimes they can get a bit funny about using randomly listing all these additional bloods when maybe they feel that wasn't necessary. So routinely, that is sort of your core bloods, but then do have a conversation to say, do you know what, there's something going on here, bit tricky, the patient's presenting this way, shall we do some additional sort of clotting times or whatever. But that's, yeah, your basic bloods. Oh, and also an HbA1c, because a lot of people, especially elderly, can slip into type 2 diabetes without sort of dramatic symptoms, but their glucose could be elevated. So an HbA1c as well is always useful.
Okay, thank you. Next one is what kind of, we've got some great questions coming in today. I always think these are some, I feel these are some of the toughest questions ever. But remember, I'm not a clinician, so you know, they're tough for me, but you seem to be answering them fine. Which is why we've got you on as the speaker and not me doing a session on leg ulcers. What kind of cultural beliefs may influence a person's involvement in their care?
So in terms of culture, it depends on the provider of the care. There are some cultures that very much they're quite inclusive with regards to the care being delivered. So it could be a male, for example, who would not want a female nurse delivering the care to them, or it could be a male nurse that they would oppose delivering care to a female, for example. There's also, in terms of products, sometimes that we need to be mindful about what's within products as to whether there's, things that they need to avoid. I know we're better now in terms of products, aren't we, with animal derivatives, for example. But it tends to be also, times of fasting or prayer, what time that you visit people. But there are some cultures who care very much their community looks after their own, and they don't rely upon or want other people coming in to deliver that care. So sometimes it's about maybe educating to allow them to do that themselves with support, rather than us actually providing that ourselves, if you see what I mean. So it needs to be mindful about the impact, I think.
Okay. There are so many questions coming in. I'm going to just choose another two, I think, which is probably about as much time as we've got that we've got enough time for. I know I say this all the time, but if you are watching and you sent a question in, what we'll do after this is we'll create a list of all of the questions, and then we'll basically respond to them in writing and put them next to the presentation on our website. So we do apologize if we haven't quite got through to your question, but with the amount that we've got coming in, we'd be here until, well, very late, I would imagine. So we don't have time to do that. The next question then is, how do I know if the patient has cellulitis versus general redness of the skin?
Yes. So cellulitis is it's unusual to have bilateral cellulitis. I'm not going to say impossible, but it's unusual. So people who have red leg that's associated with chronic edema, it's usual they have it in both legs. So if you have a presentation where both legs are red, hot, swollen, it's likely to be with chronic edema than cellulitis. Usually if people have cellulitis, it's the same if it's in one leg. It could just be venous disease associated, so you need to look more widely. Often if people have got that degree of cellulitis, there will be some systemic sort of symptoms as well. So check temperature. Is that elevated? Are they feeling unwell? Is there a bit of a tachycardia? The pain can be quite different and very acute. The limb is very hot. And it's a spreading. Often with red leg, you get like all the leg or the lower leg, or sometimes up to the thigh if it's all edema. But with cellulitis, you'll find, especially if there's a wound, it's a spreading infection from the source. So just check out systemic problems as well as where the redness is presenting. Okay.
This is the final question, and I'm going to see how quickly you can answer it, quickly and effectively, obviously you can answer it, because we really are pressed for time. How do I measure a wound if there is a lot of maceration around the wound edge?
Yeah, that is tricky. If there's a lot of maceration, if you can determine the edges, do it. If not, what I would do, take a photograph, get the maceration under control, which you can do pretty quickly with good, absorbency, skin care, and then measure the next visit or in a week's time when you've got better defined edges. Wounds, the scenario will change quickly once things are under control. Don't beat yourself up that you haven't got it today. If it's not that evident, treat the surrounding skin and then remeasure when it's clearer. That would be my answer, what I would do.
Well, I think that's a great answer. So can I just thank the Ergo Foundation. And it's important that we define that it's the Ergo Foundation rather than just Ergo, because it is they do run as separate entities. So thank the Ergo Foundation for supporting this event. It's been really informative. There have been 800 of you or so watching throughout the evening, which is a fantastic number to give up your time on a Tuesday evening. I don't want to embarrass Sarah, but I know that it's her birthday tomorrow. So the fact that she's given up her valuable time to do this presentation today means a lot, because I tend to celebrate my birthday for about a month, so I wouldn't have done it. So thank you very much. Thank you very much, Sarah, for doing that. And if everyone can just wish Sarah a happy birthday in the comments, we'll make sure that we pass those on. So thank you very much. There should be some links now coming up on your screen, both to Legs Matter, the Ergo Foundation, and a way for you to be able to and the link for you to be able to download your certificate. Thank you to my team as always, and thank you to Mold Digital for sorting this out flawlessly as ever. And enjoy the rest of your evening, everybody. Thank you again, and we look forward to welcoming you. Oh, there is one more thing. Sorry, I'm just being reminded. There is one more thing. Wound Care Today, our annual conference, is next week, Monday and Tuesday at Milton Keynes. It's a free to attend event. You can come for one day or both. We've got both clinical and personal development sessions taking place. A huge exhibition with everyone you'd expect to see from industry, showing some really amazing products and innovations. Sarah will be there, so you can come and take her cards and flowers for a birthday in person. I will be there. I'll be hobbling around with my broken legs, so come and say hello to me. Hopefully we'll get to meet quite a few of you next week. Go register online. Thank you again to Ergo Foundation. Have a good evening, and we'll catch up with you soon. Goodbye.